That was great. We have some time for some questions, and you can still get out to see the baseball game. You have a mic?
Hi, I just want to say thanks for two really great talks about, like you said, such a really important topic that often gets overlooked amongst lots of important health policy topics. I am from Montana, and so my question often for things like this, I love the Commonwealth Care Alliance model, but it's something that I feel like maybe works well in a place like Massachusetts that has this really high volume of healthcare workers and healthcare professionals. And do you have any sort of thoughts about how something like that could be scaled in a place where, or expanded to a place where that's not the case, places that have shortages of
I have a great example, and it was an entity that we learned a lot from. It was one of the originals in Wisconsin, Central Wisconsin Community Health Partnership, in a little place called Eau Claire, Wisconsin, and they served 5 counties, and they had about 3,000 to 4,000 people, frail elders, homebound people with developmental disabilities, and interdisciplinary teams. And their nurse practitioner would get on the roads, and they would go 75 miles. And I'd say, how do you do a geography of 130 miles? And it was the same system, but then when some of the people from that program came to visit us in Boston, they realized that, wait a minute, if you're trying to go from South Boston or say from East Boston to South Dorchester at 4:30 in the afternoon, you could do that 75 miles in Wisconsin more efficiently. And also you don't get a ticket every time you park your car in a residential. There's no such thing as that. So Community Health Partnership, and there are a few others like that, have actually demonstrated how you do this in large areas. Now, Wisconsin seems really rural compared to us, and maybe it's not compared to Montana, but there's another story about it, and they actually have did a remarkable job. There's some politics that happen in Wisconsin. For this purpose, I'll say there are models of how you would do this, and get in the back of the pickup truck and get that person out there.
The other question I would have is, are you seeing telemedicine in any of the models? Because that's in some of the rural states, certainly for some of the behavioral health, where you just don't have a lot of access to behavioral health teams. Some of the academic health sciences centers will have geriatric psychiatrist or behavioral health specialist, and you can see the patient who might be 200 miles away, and they can make recommendations. So are you seeing any?
Well, there is one in New Mexico that's really the lead project, Echo,
yes.
Sanjeev Arora, and they started with bad clinical hepatitis C, and where everybody was coming in to see the specialists, and in fact at the University of New Mexico Medical School, and they found that people were dying, viral loads.
Yes, a question.
Yeah. So what we saw tonight is very dense informationally. As someone who, from the community, recently took care of my 96-year-old mother for 16 years until her death, how can we get information into the community in an understandable format on an ongoing basis so that people who are prepared, in the concept of it takes a village to be able to do this, to understand our healthcare system, and big changes with the ACA, and I just said, do we remember from the first class when we went over the ACA what exactly those changes were, because it escaped me for the moment. But how can we do this? Because medicine is getting more complex. Our understanding of how to be healthy is getting more complex. Those tools are going to have to get down into the community so you can understand those. Things like MS, theoretically we're going to have more effective treatments in the next decade. That will be very helpful, but we're going to need to understand those as civilians so we can effectively interface with the medical profession. How are we going to do this? Because I think we are not doing it well now. You get to a certain age, you are taking care of a parent, you are taking care of a disabled neighbor or a child or whatever, and it requires a ramp up of knowledge that is huge and an understanding of resources that are not easily understandable. And I hear what you're saying about the alliance, that you're going to try and redo the model so that those are more embraceable. But how are we going to do that so that people understand the system and the options and the science?
Well, that's a very comprehensive and extremely well articulated, question for all of us. I think some of it is when you say it takes a village. I mean, that really resonated with so many people, that idea. And I think a lot of what we have to do is take this out of, the healthcare system being over here and everybody else being over here, and be more integrated. And we need to train coaches. I mean, coaches are very popular now, health coaching, but it's really true that what you're talking about, broadening everyone's understanding of how we care for one another, is just totally changing the paradigm and saying we don't have a healthcare system over here and a community over here. This is all, and that's what Bob was saying. I love how you said the nurse practitioners are like the daughters or the daughter-in-laws. It's breaking down those silos and not trying to have all the knowledge over here. And of course, with the internet, it's very different than it was. But I think the possibilities are there, but I think conceptually, it can't be that there's the healthcare system and then everything else. I think it has to be what you're describing, which is community by community. So you take this community in Montana, what is it going to take for that group of people to care for one another? And that's very different from saying, let's fix the healthcare system.
There's something about the barriers to a medical place, the doctor's office building, the hospital, the clinic. The idea, it's a different paradigm when professionals go in. We're the visiting team, we were into somebody else's home, and and I think that broadening the clinical teams to include peers and to include we have to do it. I think. And then maybe some of it is breaking down the jargon and the inside speak. We all have our own, it is absolutely critical. And I don't know if I have anything more to add.
Well, I think I was so impressed with these women who spoke at this conference in Washington, and what was, their passion for this, and the fact that they had lived through this was something. 20 years as a nurse practitioner, I couldn't speak the way they could speak. This woman said, when I had my stroke and I needed a wheelchair, my family told me I had to live in a nursing home, and they put me in a nursing home. And, it took her years to figure out, and there's a video, one of the videos that's on YouTube. It's called The Sunshine Folks in Maryland. You can take a look. And it shows her in her home getting around with her motorized wheelchair, and she's very independent, and she's extremely articulate. So again, sometimes, as Bob said, this peer, the people who've had the experience of going through it, I just think, that's largely what we need. And your experience, all those years of being a caretaker, you can help someone who's starting out and just beginning to be a caretaker better than the medical establishment could help them.
Any more questions?
I feel like we have a really good picture of how to move from a nursing home to a community care facility, but Dr. Master, could you speak about how you find your clients, how they become integrated into your program so that they're not going to hospitals every 2 weeks? So there's a number of different ways that happens, but in our senior program, there's voluntary enrollment. We're regulated by Medicare Advantage rules in terms of, and so they may be referred by their own physician, and so they've seen a physician. Maybe they've had a decades of a really positive relationship, but that relationship's attenuating now, that they are no longer able to get to the practice of the office, or there's cognitive impairments. And so we work with a number of primary care practices that make that referral so they can get an interdisciplinary team. They have to enroll with us. We have to become the Medicare and Medicaid program. We have to go through all of that. And so that's one way. Another way is that we will get referrals from hospital discharge planners, or hospitals that person is in and out of the hospital. Their primary care once was meaningful for them, but no longer is because of those needs. So we'll get that. We'll get that referral. In the case of Mary, whenever anybody goes from the Mass Hospital School to independent living, we get called because we're one of the few entities that can put an interdisciplinary practice. And so in some ways, you get your referrals by you want to believe, providing value or perceived, hopefully real value, or, in ways that others don't, and others in the healthcare system or word of mouth, send those referrals. Just in the last few weeks, we've actually had our first kind of mega advertising campaign where we actually went on TV and had spots, and it's the first time ever that somebody ever advertised for a kind of down and out homeless person. This is not the smiling family on the, having a wonderful time on the side of the bus. And we don't know what that, that may be new for us, but that's how we get it.
I saw an advertisement on the bus, like
Yeah.
bus, and it says, I'm a complex person,
Yeah.
and the humanity is kind of a connection to what you're talking
That's what it's Yeah, we actually thought it was pretty amazing,
He was in a wheelchair. and all
Yeah,
that,
yeah, yeah.
I am a complex person.
Yeah. You like that
That was a good thing.
great. Fantastic. We'd never done anything like that before, and so yeah.
I guess maybe though in further answer, maybe you could take a few minutes and just talk about how, you said you're consumer governed, but maybe you could talk about how the disability community has helped to build the organization and is also bringing people in to it.
Yeah, no, that's right. I didn't. There's so much talk. So much of our learning has really been through the disability community and Centers for Independent Living and the philosophy, an independent living philosophy that is very, very different than the kind of the medical philosophy. And you said it. I mean, that in an independent living philosophy, the goal is a self-determined life. It isn't necessarily safety, and it's a self-determined life, and so going back decades, working with that community and people over a long period of time who really shared a very, I would say these are horizontal partnership relationships. And the word patient doesn't in any way convey what that relationship is. And so Commonwealth Care Alliance really came about in 2003-04 when we saw this opportunity to be on the ground floor of the next wave of demonstrations that have culminated in the ACA. We incorporated this entity where our Boston Center for Independent Living, another Massachusetts advocacy organization, a Community Catalyst, and a third, Healthcare for All, that was promoting universal entitlement, were our corporate members, and they select the board of directors. And we hear about it when things aren't working, let me tell you. So kind of we work for them, and so that changes the paradigm too. And it's extraordinarily rewarding. That's the corporate structure, and it's given us a unique learning. So a good example of this learning, which is, if you go to most managed care organizations or most HMOs, the question is, it's the concept of who owns the network, who's the specialist. The plan would say, this is our specialty network. Are you in network? Are you out of network? Or non-covered? Well, in fact, if you look at the independent living paradigm, it's not our network, it's their network. People come with lifelong relationships in many ways with oftentimes pediatric specialists or vendors or agencies or durable medical equipment, clinicians or providers. And so the job is, you got to build that network. It's your network, not ours. You tell us who you need to see, and we got to build a contract model around all of that. That's a paradigm shift. And you would never, you would think you were talking about introducing bubonic plague into Boston. If you raise the issue of this this approach to typical managed care organizations. And in fact, it's not a problem at all. It's the easiest thing in the world to do. You know, and no such thing as out of network. And that's a good example of the learning from the independent living community.
Any more questions?
I have a question. My brother's in North Carolina, and she's in a nursing home. And I'm wondering about, like, I talk to her almost every day.
Mm.
And I can see things that I don't like, and I don't know how to live, and I don't know how to tell. So what I did is I flew there, stayed in a hotel, rented a car, and took Mom out for 3 days.
Yeah.
I took her out, and they couldn't believe it. I took her out, and she was walking. They couldn't believe the whole thing. I took her out for lunch. I took her in a grocery store. I mean, they.
Yeah.
I mean,
It's got to be painful for you to.
It
you
is
think, I know.
every day.
Yeah.
I mean, it's very.
Yeah. Is there other family down in North
My
Carolina?
brother is and his wife.
Yeah.
They have a whole different concept than I do.
Mm-hmm.
It's very. But I mean, I think healthy. I think she should get more exercise. I think.
Is
But
there?
she wants to stay in North Carolina.
Yeah.
They're through the ombudsman program, so every nursing home in the country does have a state ombudsman who's designated through the Department on Aging, and that's somebody who can advocate for things like if she wants to go out and have, go out and have lunch, once a month or once a week, or, if there are things, if she wants to get regular exercise and she doesn't feel like she is getting that, she can have.
She says she doesn't.
Well, so the ombudsman can help her understand and work with the staff, and there's somebody who does a lot of negotiating, but they tend to be helpful. So that might be and there will be someone identified for that nursing home, and it has to be posted in the lobby or somewhere, or you could just ask who is the ombudsman, and they might be able to be helpful.
Thanks.
Hi. Is the SCO program specifically for seniors that want to live independently? What about the seniors that are resisting living in the home because there's too much to manage and want to live in a community? How is that financed, or how?
It's not. The SCO program is for any senior that's over age 65 that has Medicaid. So it could be an ambulatory population, although we have very few of those. And we do have people in varying forms of assisted living. So we would spend a number of dollars on an individualized care plan for people that have long-term service support needs. But if you have 50 in a home, and that amount of money could be $1,700 or $1,800 per person per month, you can aggregate that, and that's actually a model that that opens up assisted living to low-income people. That generally that's been for people that could plunk down a hunk of change and buy their way in. And so that those are some of the models there. Is this somebody that you're thinking of that actually wants a supportive living or nursing? The other is foster care. This is there is a Medicare. Our Medicaid program is developed and it has for years an adult foster care benefit. That where it's essentially another family structure, and there are organizations that do the matchmaking with families, and there's payment to families for that. And these are all things that weren't there way back. I mean, this has been the proliferation of a whole range of Medicaid-funded alternatives, foster care or assisted living.
And some of it is probably community. Some of it is probably also community by community. I mean, there might be foster care available in some communities and not others. And a lot of these programs are really state to state. So it might be that some of the states have more designated beds available in assisted living for low income or dual eligibles, but other states don't. So and again, it's very patchy even by community what's available, and it changes a lot. So with all this new you know, the new Medicaid managed care, like in New York, they're doing different things all the time.
And I do want to say, when you are eligible for Medicaid and you have Medicare, you can put all this together. What are the vexing problems, or what about people that are just above that and yet they don't have a lot of discretionary income to buy long-term care services? That is a huge gap. And Jean ran a task force that many of us were on. If you ever try to, from a policy point of view, develop policies over time to try to address that issue. But that's a huge issue, and it doesn't feel very fair necessarily.
Why is the percentage of residents in southern New England and nursing homes so much higher than it is in northern New England?
That's a very good question. There could be a lot of factors. It could be availability of, or lack of availability of other alternative services. It could be culture. It could be the way some of the states and some of the families and some of the medical professionals think about those options. There's just a lot of state-to-state variability in all kinds of aspects of healthcare that are quite interesting and difficult to explain.
Okay.
Well, please join me in thanking our fabulous speakers.